Good morning, everyone. I want to express my appreciation for all of the speakers this morning. My mind's going a mile a minute thinking of all the information that we can bring into our work and into our programs. So if your mind's also going a mile a minute, maybe you can join me and just take a breath, appreciate what was shared this morning, give thanks for that, and prepare for a whole other session of amazing information. Because the next session we have coming up is influenza and COVID-19 vaccine updates. We're very fortunate to have Dr. Skowronski, who leads the Influenza and Emerging Respiratory Pathogens team at the BC CDC, joining us to share information about COVID-19 and influenza vaccine effectiveness. Following her presentation, we'll have a panel discussion where she'll be joined by Dr. Manish Satarangani and Dr. Jane Finlay. Please refer to your program for their full bios. They are also bringing a wealth of information. You can submit your questions via Slido, and for those in the room, we'll have the 2 mics to take questions as well. So without further ado, I will turn it over. Yes, indeed, now for something completely different, but we all have our place, I guess. So what I'd like to do is, first of all, thank you to the organizing committee for giving me this opportunity. What I would like to do this morning is share with you some of the lessons that I've recently learned, both from the work of our own team, but also the work of others. And this is just a small sampling of a lot of work being done in both of these domains. Our work, anyway, has been entirely publicly funded, but where there may be evidence that has been sponsored by industry, I will certainly call that out. This is what I'm hoping to cover for influenza. I thought you might be interested in update on evidence related to enhanced influenza vaccines, and should we be preferentially promoting and paying for one over the other. I thought I'd review some of our recent vaccine effectiveness findings from these very atypical past 2 influenza seasons and the coming WHO recommendations. I also want to give you a chance to see hot off the press, really, most recent update to seroprevalence findings in BC from the autumn 2022, inclusive of increasing contribution by BQ1 circulation, and what that means in terms of hybrid immunity and implications for booster dose recommendations. And then I'm going to turn the tough part over to the panel to discuss future directions building on this recent evidence. So that's what I'm hoping to cover. Let's see if we can do it in 30 minutes. So this is the list of available and authorized influenza vaccines in Canada now. You can see that we have we're quite fortunate. We have about a dozen now available in Canada to choose from. We do assume that the vaccine effectiveness for each of them may be considered, if not identical, at least comparable, with perhaps the exception of the enhanced products. And I've shown you the proportionate use of these various vaccines, both in Canada and in British Columbia. But there are 2 vaccines in particular, the high-dose influenza vaccine and the adjuvanted influenza vaccine, that have been promoted on the promise of enhanced vaccine effectiveness. And so I do want to touch a bit on the recent evidence related to that. But before I do that, I want to make sure we have a common understanding what we mean by vaccine effectiveness. When we say vaccine effectiveness, it's basically a measure of the reduction in risk of whatever influenza-related outcome we're referring to in comparison to a comparator group. And typically that comparator group for us would be those who are unvaccinated. But when you have universal influenza vaccine programs or groups where there's very high vaccine coverage, that unvaccinated group may not be representative. They may have special characteristics. And so rather than using the unvaccinated as a comparator group, we might instead use those who received a different one of those dozen other influenza vaccines as the comparator group. When we're comparing to unvaccinated individuals, we refer to that as absolute vaccine effectiveness. When we're comparing product to product, we call that relative vaccine effectiveness. But relative vaccine effectiveness is then hard to understand or interpret in terms of the absolute benefit or the absolute reduction in risk that's needed to derive things like the number needed to vaccinate and cost, et cetera. So I want to share this simple formula. Maybe it's not that simple, but now that I think about it. This formula, write it down. It's very handy for you to be able to critique and evaluate enhanced relative vaccine effectiveness and therefore the absolute protection offered by enhanced vaccines. And basically the absolute vaccine effectiveness of enhanced vaccines is the vaccine effectiveness standard dose or standard product plus the absolute increment, which is the relative vaccine effectiveness times 1 minus the vaccine effectiveness standard. What all of this translates into is that unless the vaccine effectiveness for the standard product is 0, the relative vaccine effectiveness is always going to be less than the absolute increment in vaccine protection. And what this further means is that if the vaccine effectiveness standard is 0, then if you plug into that formula, you will see that the vaccine effectiveness enhanced must equal the relative vaccine effectiveness. Why am I troubling you with this? Because when we're going to critique these coming studies of enhanced vaccine, mostly based on relative vaccine effectiveness, unfortunately, we do need to appreciate this concept. The other important concept that I want to underscore in relation to this formula is that for the same relative vaccine effectiveness, the higher the vaccine effectiveness of the standard product, the lower will be the absolute gain with the enhanced vaccine. And you can see that in some instances, when you start with quite low standard product vaccine effectiveness, even with a relative vaccine effectiveness of the same, say 20%, the marginal gain may be greater, but where you end up in terms of the absolute enhanced vaccine effectiveness can still be quite low in some instances. So what I'm trying to say to you is don't be blown away by what seems like very large relative vaccine effectiveness estimates. We need to anchor those in what that means in terms of the absolute vaccine effectiveness. So these are two recent studies, randomized controlled trial, yay, or at least they call themselves that, studies of high dose versus a standard dose inactivated influenza vaccine in adults 65 years of age and older. I say they call themselves randomized controlled trials because they actually are pragmatic. The first one, a cluster randomized control trial, means it's open label, et cetera. And the study most recently published by Johansen et al. Actually wasn't even intended to look at clinical outcomes. It was a kind of a pilot of a pilot. It was a feasibility study that just happened to secondarily look at clinical outcomes as well. So again, you have to be cautious in interpreting these. And I've seen people cite this Johansen study as a recent RCT, which makes it sound definitive, but we have to be so cautious even when studies refer to themselves as RCTs. The first one by Saad et al. Was in nursing home residents during an H1N1 season, and Johansen et al. Was in the Danish population 65 to 79 years of age. But what I want to point out, first of all, you'll see in the Saad analysis, the relative vaccine effectiveness against hospitalizations was in the range of 10 to 20%. And these are for relatively non-specific outcomes. This isn't lab-confirmed influenza, so pay attention to that. But in Johansen et al., you can see that against hospitalization, pneumonia, and influenza or respiratory, these are quite dramatic relative vaccine effectiveness estimates, aren't they? 40 to 60% relative VE. And note as well that against all-cause mortality, Johansen was reporting a relative vaccine effectiveness of about 50%. That's about a halving of all-cause mortality during the study period for relative to those who received the standard dose product. Now, I want us to think about, and I want to illustrate to you, if I can advance the slide, why we may want to be cautious in interpreting that. Have we run out of batteries on the remote? Is that possible? Yeah. Which one should I use? No, it should be advanced. No. Oh, it's going now. No, we need to go back now. Back, please. Yeah. Am I going to have to ask you to advance, do you think, or no? Okay. So let's take a look at how valid those findings by Johansen are. A relative vaccine effectiveness against all-cause mortality of 50%. Again, this was a feasibility study. Well, this study spanned 7 months in Denmark, and Denmark, like us, experienced a late season 2021-22 influenza epidemic. And you can see that across the span from October to May, the 7 months that this study took place, there was lots of other respiratory virus circulation, including, by the way, COVID-19 at that time. And Denmark, like us, attempted to measure vaccine effectiveness against influenza and against not only outpatient but inpatient severe outcomes of influenza. And they reported an influenza vaccine effectiveness of 0 during that period. And yet this Johansen study is reporting a relative vaccine effectiveness against all-cause mortality of 50%. Well, remember that formula? This is where it becomes handy. When the vaccine effectiveness is 0 and the relative vaccine effectiveness is 50%, that essentially means that the vaccine effectiveness of the enhanced vaccine equals the relative vaccine effectiveness, which means that this study, if you're to take it at face value, would be essentially saying that the high-dose influenza vaccine prevented half of all deaths during the 2021-22 period in those 65 to 79 years of age. That's half of all deaths due to accidents, due to trauma, due to cancer. It's all-cause mortality. Well, I guess I'll ask you if you think that's possible. But this is, again, why we need to be really careful, even when it's an RCT, to critique the findings and what they mean. There are also observational studies in addition to randomized control trial studies, and these you have to take even more carefully into consideration. This is a meta-analysis by Lee et al. This is funded by Sanofi, as were both of the other studies. And I just want to highlight the relative vaccine effectiveness estimates here, about 15% against lab-confirmed influenza, and then against more severe outcomes. These are based on again, clinically coded, non-specific, so not necessarily due specifically to influenza. And what you can see is that the relative vaccine effectiveness against the non-specific, the more non-specific the outcomes, the greater the relative vaccine effectiveness. That is completely paradoxical to what you would expect. You would expect that the vaccine would work best against those outcomes that are more specific to the vaccine intended to prevent them, influenza. So that again would be a signal of caution required in the interpretation of these observational studies comparing high dose and standard dose vaccine. There are also studies of adjuvanted vaccine versus standard or high-dose influenza vaccine. Again, observational evidence, one by Coleman. Each of these were funded by the manufacturer of the adjuvanted vaccine. And you can see that the vaccine effectiveness in Coleman, again, relative vaccine effectiveness against a combination of hospitalization, emergency department, or outpatient care. Very strange to bundle all of those together. We would expect differences based on the outcome of about 15%. In McConaughey et al. Against severe outcomes ranging about 10 to 20%. And in adjuvanted versus high-dose vaccine, this meta-analysis by Dominic et al., again funded by Seqirus, again using non-specific outcomes, there were small and inconsistent differences. And this is important in the comparison of the adjuvanted vaccine versus the high-dose vaccine, ranging from about -15% to +10%. In other words, nothing really consistent in comparing high-dose to adjuvanted vaccine. And what this meta-analysis called out was that perhaps the greatest determinant of differences in studies between the high-dose and the adjuvanted vaccine were, first of all, whether they used more or less specific outcomes, and also who sponsored it, who funded the study. That tells you something very important, I think. When we look at studies funded by the FDA, you can see in this multiple vaccine comparison of adjuvanted, high-dose, recombinant, or cell culture vaccine against the standard quadrivalent influenza vaccine that the differences between the high-dose and the adjuvanted vaccine are what I would call minimal. And the greatest difference, actually, from the standard vaccine is with the recombinant vaccine. So in summary, what do we take away from the comparison of, I don't know why I'm having such a hard time with this, of the enhanced vaccines? Well, first of all, there's no additional RCTs to assess enhanced vaccines, absolute vaccine effectiveness against lab-confirmed influenza. There's no head-to-head RCT comparisons of enhanced vaccines. And observational studies are showing maybe 10 to 25% relative vaccine effectiveness against influenza illness compared to standard dose product, 10 to 25% against hospitalization, except that in some instances, the estimates are very surprisingly high, suggesting we need to be cautious about bias. And observational studies where we see comparison to each other, we see small and inconsistent differences between the enhanced products. So the takeaway for me from this is that in the end, it is a socioeconomic decision whether to invest in these enhanced vaccines and whether the marginal gains that we see warrant the enhanced costs. But there is so far insufficient evidence to prefer one enhanced vaccine over the other. So then it does become a relative cost comparison consideration foremost. And the bottom line for me is these increments are not the radical transformation that we need to see in influenza vaccine effectiveness, which is recurrently suboptimally performing. We need much better options that address the root cause of that suboptimal vaccine performance. And that's not what these enhanced vaccines are offering, not at this stage. So I'd like to talk next about the findings that we've had for influenza vaccine effectiveness over the past 2 seasons. The 2021-22 season, as I say, was a late season influenza epidemic, and we were quite despondent that we might not actually, are you going to help me here? That we might not You want me to hold it over my head? Okay. We might not be able to, there we go, that we might not be able to measure vaccine effectiveness. And you can see we had that long period through the influenza season with one influenza H3N2 detection. That's quite disappointing when you're trying to measure vaccine effectiveness, let me tell you. But then we got this late season That came across wrong, but you know what I mean. Late season influenza epidemic. And we measured a vaccine effectiveness of about 35, 36%. With wide confidence intervals, and we've been doing this now for 15 years, measuring real-time influenza vaccine effectiveness using a design that we developed called the test negative design that's used now by others. But when we compared our estimates, despite those wide confidence intervals for the 2021-22 season, to estimates that I'm proud to say came later from the US CDC and the European CDC, you can see that our estimates were pretty much bang on, about 30 to 35%. And these estimates are, again, as I say, suboptimal. They are pretty much on par, though, with what we've seen for the past 10 years at least for H3N2. Typically less than 50%, often less than 40%. And this is late season, so there may have been some waning also factored into that. And this is our estimates for the most recent season. So whereas the 2021-22 season was late, we had an unusually early, as you know, current influenza season that peaked in November. That's quite unusual in week 47. But you can see, perhaps because this was earlier, perhaps because it was antigenically matched, whereas last season antigenically mismatched. Perhaps because there was a pause in influenza circulation over the course of the pandemic, so less likelihood of some immunological interference from circulating influenza viruses more recently. I don't know. But the vaccine effectiveness is pretty decent. It roughly halved the risk of influenza. That's in absolute terms, and it was comparable across age groups. This is, as I say, pretty good for H3N2. The other networks globally that we collaborate with in the US and Europe are a little delayed in getting their mid-season, which is actually end of season now, hopefully, estimates out. And you can see, though, that from the US, this estimate from the Marshfield Clinic is, again, very similar to our estimate, roughly halving the risk of influenza. I do want to point out one interesting finding this year, and that is because of the atypical features of the influenza season, with children disproportionately affected. You'll remember that there were children who died in a very short period of time, tragically, in the fall. We were very concerned to figure out if there may be something particular going on that might have been driving that, recognizing, of course, everywhere was experiencing a similar kind of a pattern of disproportionate involvement in children. Well, in doing so, on our team, Susanna and Sam, who do all of the genomic sequencing, sequenced the viruses. And what they've found compared to the other provinces that participate in our vaccine effectiveness network, the SPSN, was that there was a particular variant that was circulating in British Columbia that comprised more than half of all of our viruses, less than 5% in the other participating provinces. It's that tangerine-colored bar. That's the naming convention we have to deal with. There's no Kraken here. There's no Omicron here. That's the kind of conventions we have to deal with, nomenclature for influenza variants. Anyway, so I thought to make it easier, I would color code it, or just call it the tangerine variant, or we could call it the Danuta variant if you want, or probably, it'd be better the Susanna variant. But in any case, you can see, though, that we had a lot more of that particular variant that has an important substitution, a mutation in the hemagglutinin head, and how much that may have contributed, compounded what was already a season of disproportionate pediatric involvement, I don't know, because more than 85% of that tangerine variant was identified in people under 25 years of age. And this was quite unusual. We looked at more than 17,000 sequences in GISED and found only about a dozen other of of this particular variant uploaded by January. So it was quite unusual, and it's just something we are interested in now. Fortunately, it did not become pervasive globally, and the vaccine effectiveness was slightly reduced against this variant. But taking all of our VE findings into account, as well as the virological patterns globally, the WHO, as you may recognize from just last Friday, I think it was, announced the updated components for the coming 2023-24 Northern Hemisphere season and opted to retain the same H3N2 vaccine component, switching up only the H1N1 for the coming season. And Susanna and Sam tell us that they approve of the WHO's decisions, that they're on par with what they would have expected. So that's great. I trust them. And the WHO. Oh, there we go. Can I just touch a little bit more on the patterns, how unusual, atypical this past season was? This is the mid-season report from FAC, and in the table, you can see that they highlight sort of the unusual features. First of all, you'll notice that the proportion for an H3N2 season, the proportion of detections in children versus elderly adults was completely flipped compared to what we would have seen, and I've highlighted with the red box, compared to that other H3 predominant season pre-pandemic. We typically expect H3N2 to be hardest on the elderly. Children certainly can propagate, amplify, but this complete reversal in the proportionate distribution is quite unusual. Now, that could reflect, because this is just numerator data, it's just cases, that could just reflect different testing practices. Maybe we were testing a whole lot more children, and so we need to see that as percent positivity, not just the distribution of the cases by age group. And you'll also see from the impact pediatric hospitalization data that it was early and that the number of hospitalizations exceeded the maximum historical average for the autumn period, and in fact was showing that early on disproportionate involvement of older children compared to what we might have expected. But I do want to highlight in the hospitalization data from impact, also shown here, the number of hospitalizations has increased in children this season, but the percentage that ended up in ICU, in other words, the severity amongst the hospitalized, was not increased compared to previous seasons. That's another one of those devil in the details, important things to flag, suggesting that it wasn't more severe, it may have been more cases, the same proportion hospitalized, but with more cases, that translates into absolute terms, more of those hospitalizations that you see in the numerator count, right? And I also want to highlight, I hope you can see this, but this is really interesting work done by Shanae Kim on our team, where she looked at percent, and she's here in the audience, looked at percent positivity for influenza A by single year of age group, which is in the x-axis, and each of those panels represents an influenza season from 2014 to 2022-23. And you can see that in terms of percent positivity, the top three panels, the first panel is 2014-15, a definite H3N2 season. And the middle panel is an H1N1, and then on your side, the right-hand panel is a 2016-17, also predominant H3N2 season. And you can see that there is a U-shaped test positivity, highest in the older adults, right? The middle three panels were mixed. Oh, and in 15-16, that was an H1N1 season in the middle of that topmost series of panels. And you can see that the risk is distributed across the population because younger people do get H1N1 disproportionately. In the middle three panels, those are mixed seasons, and you see a similar kind of profile of percent positivity by age, kind of more evenly distributed. Look at the leftmost panel, That's the 2020-2021. And I think we found about 20 influenza viruses, despite 30,000 or more tests that were done that season. So we had a real pause on influenza circulation. We did no VE estimates that year, by the way. In 2021-22, you can see the percent positivity, that pink line. There is a hump, right, in those children and young adults. It's flatline in the elderly adults. Perhaps they were still self-isolating. It wasn't affecting them. But look at 2022-23. And the percent positivity profile now is very different, isn't it, than previous seasons. And Sinead has shown that in a heat map as well. You can see the seasons in the x-axis in that heat map, and in the prior pre-pandemic seasons during H3N2, dark purple amongst the very old at the top of the y-axis, but in the recent seasons, H3N2 really concentrated in children, particularly in 2020, 22, 23, coming down toward the younger age groups being much disproportionately affected. And you can see that also actually in the RSV positivity as well. Same profile with disproportionate involvement in 2021, 2022, following virtually no detection in 2020, 2021. And then in 2022, 23, similar again, but what we're seeing in 2022 is a kind of a return almost to that expected pattern of the most young being affected. Typically, we think of RSV disproportionately affecting those under a year, even under 6 months. And look at how high up that heat map goes in 2021-22 in the green bars, and it's starting to shift back down again, we hope, in 22-23. So, and this is another analysis again getting at, okay, maybe there were more RSV cases in older children in 2021, 2022, but in this analysis from BC Children's Hospital, where they did indeed pick up proportionately more children in the 1 to 3 year age band versus under 1 year of age in 2021, 2022, that was not accompanied by greater ICU admission or greater risk of hospital admission. So it wasn't a factor of the virus becoming more severe, but likely other factors at play. So why was there more respiratory illness in 2021 and in 2022? I think you've probably heard lots of colloquial references to immunity debt perhaps playing a role. I don't know what people mean when they say immunity debt for starters, but we don't need to invoke that to be able to explain this pattern. And probably what was happening, in fact, was a non-specific likely temporary cohort effect as a result of the pause in respiratory virus circulation during the pandemic. And as a result, we accumulated several cohorts of susceptible children. And there's no such thing as a free lunch in nature. The piper has to be paid. And eventually, those children had to become infected once we reopened. And multiple respiratory viruses, several cohorts of infections and reinfections, fueling simultaneous intense epidemic, basically, or epidemics. We don't need to invoke that the virus was more virulent or that we became weaker to explain that. And this should be a temporary cohort effect. It should wash itself out once those children who got away without being infected during the pandemic period become infected. And we should see that. How long that will take, we don't know. We have to keep monitoring, but that should eventually wash out, as I say. I also want to share with you, and I know I'm running out of time, but call of the panel, I can keep, okay, thumbs up, okay. Updated seroprevalence estimates. The last time we shared this with you was in August of 2022, and what I've shown here, the dark red bars are the percentage by age group and by serosurvey that have infection-induced antibody in the lower mainland population of British Columbia. And you can see that by our 6th serosurvey that took place in October of 2021, by then still less than 10% of the population had evidence, serological evidence of SARS-CoV-2 infection. But wow, what a difference a year makes, because by our 8th serosurvey in August of 2022, by then 60% of the population overall had serological evidence. And in our most recent serosurvey done in December, so spanning the autumn 2022 period, that's increased to about 3/4 now of the whole lower mainland population. We estimate overall has evidence of having been infected by SARS-CoV-2, and that's highest in children, exceeding 80% up to about 29 years of age, and then gradual decrease you can see by 10-year age band to those 80+ years of age, still less than half of them yet having acquired SARS-CoV-2 infection. And I want to underscore why that may be important, but before I get there, this is a figure showing the estimated risk then of new infection by period between our serosurveys, the 6th to the 7th, between March and August of 2020, the 6th to the 7th between October of 2021 and March of 2022, the 7th to the 8th between March and August of 2022, and then our most recent, which is the 9th serosurvey done in December of 2022. And basically what you can see from this, I hope, is that compared to the Delta Omicron periods, where there by age group was a highest risk of new infection among young children, by the BA2, BA4-5 period through the spring and summer of 2022, that pattern changed, with children having now lower risk and older adults having higher risk, but overall lower compared to that Delta Omicron BA1 period. Most recently then, in the autumn of 2022, shown in the orange line, you can see that the new infection risk is now quite comparable between age groups. And perhaps that's because much of the population has had vaccine-induced antibody and infection-induced antibody that may be suppressing circulation in most of the population, but we can see that the older and the younger individuals seem to be at comparable new infection risk. And during this period, however, if we look at the percentage hospitalized in colored bars by age group, you can see that, in fact, although the new infection risks have become more comparable, and even though older adults more than 70 years of age make up only about 10% of the population, they're still comprising about 60 to 75% of all of the hospitalizations. And so even though they may have comparable new infection risks, they're still disproportionately represented amongst the hospitalizations. And so we were able to estimate the hospitalization risk then by age group based on our seroprevalence estimates of new infection between periods, and using hospitalization data adjusted or corrected for the likelihood that it was a hospitalization for COVID-19, not just with COVID-19. And with that correction factor, you can see in orange what is the autumn 2022 hospitalization risk, and in purple what it was during the spring and summer of 2022. And the takeaway from this is that, for me, the very old, again, remain at the highest hospitalization risk. And although these are preliminary estimates, they are within the realm of what I think are conceivable estimates. So an estimate of about 5%, say 4 to 5% hospitalization risk would mean about 1 in 20 older individuals with a new SARS-CoV-2 infection might be hospitalized. That seems within the realm of possibility. 2%, that would be around 1 to 2.5%, around, say, 1 in 40 during the spring and summer period. Now, why the increase through the autumn 2022, and is it real? Those estimates are comparable to what we have preliminarily assessed also during the Delta Omicron period. So it's not, scary high. It's comparable to what we have seen previously. And I don't know. It's either artifact or it's real, right? But there is a factor that we could consider, and that is the increased contribution of BQ1 during that period. In the autumn 2022, the more immune evasive. But that's just speculative, and these are just estimates. Overall, however, the evidence in total indicates that those who have both infection and vaccine-induced antibody have stronger, longer-lasting immunity and protection. And in this meta-analysis, you can see that those who had prior infection alone, even out to 12 months, we're still having about a 75% reduction in the risk of hospitalization. That's out to 12 months. Whereas those with both infection and just the primary series of vaccination had about a 95% reduction in their risk of BA1 or BA2 with any prior pre-Omicron even infection. And comparing those who had prior infection and just the primary series to those who had booster dose and infection made really little difference in protection against severe outcomes. And you can see in the colored figures, when they compared that to those who were vaccinated only, there was, that's shown in the orange, there was, whether primary or a series or with booster doses, you can see that there was a faster waning of antibody in those with vaccine history only. They did include one of our previous 3 papers our work that we've done on this, but here you can see from analysis looking at the BA4 and BA5 period now and hybrid protection versus infection alone, that whether you had received 2, 3, 4, 5 doses, if you've been previously infected, you have long-lasting, even out, and I'll show you in a moment, even out to 9 to 11 months protection against severe outcomes. So that's to the BA4 and BA5 variants as we know it. And as I say, we show that protection lasted out to at least 9 to 11 months, so long as we could measure it. Very high protection maintained against severe outcomes. So in summary, what does the compilation of the seroprevalence and emerging evidence around hybrid immunity mean? Well, by the end of the 3rd pandemic year, we show that most British Columbians have a combination of vaccination, very high vaccine coverage, with most having serological evidence of prior infection. The accumulating evidence shows that even having received the primary vaccine series with a history of prior infection, you get this very robust protection against severe outcomes, which is the main goal of all of our efforts with the immunization program and other measures that we had implemented. In that context, then, if we're talking additional booster doses, those should be prioritized toward high-risk individuals without a history of prior infection. Whether recognized in our reportable database or self-reported. And older adults are the least likely to have prior infection and the most likely to be hospitalized. So that should be a pretty strong indication of how we should be focusing then our additional doses if on an age-based basis, if not based on prior infection history. And I would say we should consider the lessons learned from influenza. And people are asking, should we be going annual COVID vaccination. It's too soon to make that call. And from influenza and working on that for 10 to 15 years at least, I can tell you we want to avoid making the same errors we did with influenza with premature assumptions, premature recommendations beyond what's clearly indicated or that the evidence can support. That would be the main takeaway message. And the organizers will be happy to know this is my final slide. I just want to acknowledge the members of our team who have worked so hard, in particular Sam on the seroprevalence estimates, Erica on the vaccine effectiveness, and Shanae on the analysis of the surveillance data. And they have also been supported by others. In particular, I want to call out Hins Bihi, Yayak Joff, and Kate Smalina for the supportive data, and also Yin Chang for her contributions to the surveillance data as well. And that's all I have to say.
Thank you so much. Now I'm looking at the organizers in the front. Do we have about 5 minutes of flex time to take a couple of questions? Okay, I think there's going to be a lot because that was wonderful information, so timely, and great to see the local data. We do have 2 mics in the room, but we have 10 minutes. Ooh, lucky you. Okay. I'll go over to Slido first. Are there any questions we can take from there?
Yes, our top question, how beneficial is it to receive a flu vaccine at this point in the season, given the early flu season this year and peaking in November? Is the flu season essentially over?
Can you hear me? We always have concern about a potential secondary influenza B wave, and there have been some atypical seasonality features of recent influenza seasons. But at this point, we don't have an indication of that. And I would have a hard time myself promoting that people get the influenza vaccine now if they haven't already. Now, that's not to say there may be some special circumstances. Perhaps people will be traveling to the southern hemisphere. I don't know. So individual basis, that may vary, but on a population basis, I don't see a strong benefit to promoting influenza vaccine now for the bulk of the population. No debate there, it seems.
Yeah, I mean, I don't have much to add. I agree. Like, we haven't seen huge numbers of flu cases in children, at least at the hospital, for a while now. I don't know who gets the final say on when it's officially over, but that's definitely not in my. That's above my pay grade.
We have another question from Slido.
Yes. Danuta, I think you started to touch on this on your last slide. What are the implications of these findings for spring COVID-19 booster campaign?
I do think I covered that in the final slide. There may be subsets of the population for whom a booster dose is indicated, and that would be, in my mind, those without prior infection history, particularly the very old, or those who have immunocompromise, for instance. But otherwise, you saw from both the hospitalization risk slide that most people are at extremely low risk of severe outcome now due to COVID, and most of the population has hybrid protection on their side now. So for the bulk of the population, again, it would be, for me, hard to advocate for booster doses for the general population.
Remind folks in the room, we do have mics if you'd like to speak, but I think there's more questions on Slido right now.
Yes, for sure. Influenza vaccine effectiveness often focuses on infection as the outcome, which is moderate and occasionally minor, and can lead to the public to be skeptical towards influenza vaccination. Should, like COVID-19, we focus more on public reporting of influenza vaccine effectiveness using severe disease as the outcome.
There is a network called Serious Outcome Surveillance Network that monitors vaccine effectiveness against severe outcomes, and I do agree that that is important to be done. Of course, it's much more labor intensive to do that in the hospital setting. Our SPSN network focuses on outpatients. It's more efficient for us to do that. We do variant level, and it's mostly geared toward informing the WHO decision. We submit our findings to the WHO each February and each September to inform their strain selection decisions. But that doesn't mean that I don't think that severe outcome vaccine effectiveness is important, and we could learn from what we were able to achieve in that way during the COVID pandemic. However, there are some differences, some wrinkles that need to be worked out in those data, including, for instance, the immunization registry not capturing fully influenza vaccine, and when you misclassify someone who is vaccinated as unvaccinated, you will underestimate the vaccine effectiveness in a potentially important way. So there are some issues that need to be worked out. I've never been a real fan of using admin data sets to do vaccine effectiveness analyses for various reasons, but it's worth looking at, let's put it that way.
Yeah, so I mean, I think there's a role for both, right? So I think that it's important to look at what the effectiveness is against these severe outcomes when we're thinking about the sort of severe disease and the implications, particularly for individual patients. But I think if you're looking at the sort of overall healthcare burden and things like medically attended, influenza-like illness, and wanting to get more information overall about the sort of population of flu virus as has been presented, then you clearly will need a bigger sample set, which you're not going to get just from looking at the severe outcomes. I think I would say that looking at the severe outcomes is not easy, and it is quite labor intensive, partly because the testing patterns are different in hospital settings and between hospitals than they are in the community. And we have a lot of children that get tested when they're admitted and they have a positive test for a virus, whether that's COVID or flu or something else, but that's not the main reason why they're there. And actually, it's quite difficult sometimes to unpick the reason why they're in hospital.
And I would say also, though, although the evidence isn't strong that the influenza vaccine effectiveness against severe outcomes is necessarily higher than against outpatient medically attended illness, I think you can accept that the vaccine effectiveness against serious outcomes will be at least what we report for outpatient medically attended illness.
So I'd like to ask a question, if I may, and this might be better answered by Jane and Manish. In practice, we see lower uptake with the youngest age groups of these vaccines sometimes, and what we've heard from some parents is they don't think it's necessary, they don't think it's effective. So in light of what we've just heard in this presentation, what are you hearing from clients in the hospital, and how would you speak to parents about this?
For parents to decide to vaccinate, they have to feel that the disease is serious enough, and I don't think that message really gets across for otherwise healthy children, though this year, when they publicized the unfortunate deaths, it did make a difference and people came in to get vaccinated. Vaccine safety, we can't do too much about it. Well, I guess we can do something about the perception of that, but I think we all agree the vaccine's very safe. And then vaccine efficacy, and that's, we need a better vaccine, right? Because what I understand, Danuta, maybe you can correct me, that the efficacy in the under twos is pretty abysmal, right? It's like even 20 to 30%.
We don't have evidence for that specifically for this year.
For this year, but
yeah,
but in previous years, right?
Yeah.
So we need a better vaccine. So
I think we might have time for one more question. One more question? Thank you. Is there another Slido question?
Yes, there's a question just around NACI's preferential recommendation for flu zone high dose. In the question, they said over other enhanced influenza vaccines for seniors, but I wonder if maybe the NACI recommendation could be clarified and just some context around that.
Can you repeat the last part of the
yes,
question?
For sure. So I'll just read the question word for word. Why does NACI lean towards a preferential recommendation for flu zone high dose over other enhanced influenza vaccines for seniors if the data doesn't support it?
Some of the evidence is still emerging. You saw that the meta-analyses were 2022 and 2023. It's observational evidence, and I think probably NACI is having to, like all of us, make decisions real time that have to be subject to review, perhaps reconsideration, as evidence evolves. Also, NACI was making recommendations not for a population level, but on an individual level. And though that becomes tricky, I think it was meant to be a nod to what I also emphasize, so we're aligned that way, that this may largely be socioeconomic considerations, and it's for us to determine whether those marginal gains are worth the marginal cost, which does differ by product. That's our reality that NACI doesn't operate within. So I can't speak to what the NACI deliberations were. I can only present what I've seen, and it is pretty recent evidence and information, so it's all evolving real time.
I think that is our time. Thank you so much to the panelists, and thank you for your presentation. At this point, I'm going to turn it over to Dr. Lindsay Bowthorpe for our poster presentations.